This is a very big topic. আজকে can you follow Bengali everybody? If you don't follow Bengali, ask me. Sometimes I will speak in Bengali also as well to make you understand some topics. Anyway, so it's a very big topic. Actually, is a cerebral palsy. As you see here, the topic it is not only a very big but also a very complex one as well. So you must listen carefully, and I will go through rapidly through the slides. Later on, you will get it in the from YouTube or otherwise. You will read it later on also. So today it is as a glimpse for your undergraduate. It is enough the slides shown to you, and when if you anybody pursue post graduation in pediatrics, you will get a bigger and wider perspective of cerebral palsy. Now today, to start, so what is the definition? It is a group of permanent disorder of movement and posture. Disorder of movement and posture caused by a non-progressive insult to the developing brain in the fetus or young child up to 2 years. Now previously many things were there up to 2 years. Often accompanied by disturbances of sensation, perception, cognition, communication and behavior, epilepsy and secondary musculoskeletal problems. So this is a wholesome definition in my way. So you must, when anybody asks you, you must reproduce this definition in your writing or in your clinical class. So this is a complete definition of cerebral palsy, and as so many things are associated with it, these things, these are associated things, it must be mentioned always along with this movement of disorder of movement and posture. Understood? Next, prevalence is you see later on, you can see the 10 only in developed countries. Most children with CP are born at term. Preterm babies are mostly in our countries, low birth weight babies, but with normal birth weight, uneventful perinatal history. These are in Western countries. With antenatal cause of abnormal brain development, only less than 10% has history of birth asphyxia. Rest are preterm survivors. So less than 10% history of birth asphyxia. But this picture is otherwise here. In one large Indian study, IPGMA actually, in PGI, Chandigarh, majority were term babies with 59.8% due to congenital, 17% acquired and 20% combined ones. So you can see 50 congenital ones much higher here, and sex distribution more common in CVN boys compared to girls. Male infants with IUGR and birth weight less than 3rd percentile are 16 times more likely to have CP than males with optimal growth, and infants with weights above 97 percentile 4 times more likely to have CP. So in developed countries, CP is found affecting 1.5 to 2.5 per thousand. Prevalence in our country is around this also in our country, but in Western countries, this is the developed countries is the issue. In our country, it will be little bit more than that because obstetric care is not that developed in our country in all places. So one thing is that this nowadays the number one cause of cerebral palsy is not congenital defect or genetic defect. It is the prematurity has come up as the first, because with the improvement of obstetric care. So perinatal condition otherwise this has come down much in a rapid pace, and nowadays the prematurity is very important as the number one cause of cerebral palsy. That's very important. And prenatal risk factors you can jolly well see. Perinatal asphyxia in our country still, though not guided by low ABGAR. ABGAR is not always very good reflection of this. Neonatal encephalopathy, congenital abnormality, genetic susceptibility, multiple births. This is important. Stroke, preventral leukomalacia, in case of particularly in case of white matter injury, you call it, and intracranial hemorrhage, intrauterine. You can see this the iron magnesium potential neuroprotective and magnesium sulfate. The risk factors are here as well. All these things are risk factors, nothing important. And etiology, mostly this is important, multifactorial. So it is a syndromic approach actually. Prenatal factors 70 to 80%, and intrauterine growth restriction 34%, intrauterine infection 28%, antepartum hemorrhage 27%. You can see all these things written up there. Multiple pregnancy, perinatal factors and prematurity are also a common association. This is very important nowadays. Perinatal etiology, this is that one we found 70 to 80%. You see 70 to 80%, and rest 5 to 10% perinatal. You can see the 5 to 8 perinatal, anoxia, traumatic delivery, metabolic fetal distress, premature delivery. And next is come up postnatal, trauma, infection, sepsis in neonatal period, bronchopulmonary dysplasia, and all these things, ventilation, prolonged ventilation, preterm infants. These are the important causes. So etiology is like that. This is very important. what actually is important to you is extremely important is classification. For clinical purposes, when you see patients in ward or in your clinical classes, the physiological system classification CP is most helpful. Pyramidal, that is spastic, and pyramidal tract lesion, spastic, diplegic, hemiplegic, double hemiplegic, quadriplegic, monoplegia, tetraplegia, less important, and total all this, and extrapyramidal, athetoid, dystonic, dystonic athetoid one category, and cerebellar, ataxic type another, and mixed ataxic diplegic, and dystonia plus choreoathetoid spastic is a very mixed one, sometimes found, very rarely, they are percentage wise, these are on the rare things. Most important, these things we will get, this diplegia, hemiplegia, quadriplegia, all these things we will get. So, this classification is extremely important because clinically we will classify or tell these patients like this. Spastic, diplegic, all this, actually this classification under this spastic condition. The initial ones, those things are. Then this is one of the classification means distribution wise. Say hemiplegia, this hemiplegia is one-sided. This is very unusual. This one is very unusual. This one is very unusual. That means your single leg is very extremely unusual to be affected. Mostly this is hemiplegia you will get. This is diplegia. You will get these things here quite often. And these things also, this 50% patients lower diplegia, this is paraplegia. Paraplegia you will not get. Diplegia you will get. And diplegia means lower limbs are affected more than upper. There is also affection of upper, but much less. The affection is lower is much more. And this paraplegic type of variety is extremely rare. And this is once again, all extremities involved equally. Normal head neck control. Remember, quadriplegia, one thing is that is head neck control is more or less normal, but this is affected greatly. By rest of the body affected almost uniformly. And this double hemiplegia is something different. All extremities involved, upper more than lower. So this difference between these two, these lower more affected, upper more than lower, lower less affected. In case of diplegia, you see here we talk lower more affected, upper almost very less affected, just reverse of these two things. This is more commonly found here, everywhere. This is double hemiplegia, rather less frequent, and this is quite frequent. You will get mostly these things. So this hemiplegia will get, diplegia and quadriplegia. These three constitute the majority of the clinical cases anywhere and everywhere you find. These three will constitute the most of them. Topographic classification, another thing, the same thing almost. Here, this classification limited to the spastic types. Only we will discuss spastic types here, and it is not equally usually used with the extrapyramidal types because they are four-limb involvement. So topographic hemiplegia, hemiparesis, diplegia as discussed always, but this is about the spastic ones. This classification, topographic, little bit elaborated. You will get hemiplegia, hemiparesis, whatever, recognized after 4 to 6 months usually. Population, term infants are normal birth weight. This is important. Term and normal birth weight mostly found. Involvement either lateral side of the body, either lateral side or left or right, whatever. Upper extremities are more impaired than lower, and upper extremity dysfunction usually brings the child to attention. And clinical manifestations, early hand preference. When you read pediatrics later on, theoretically, you will see the preference, hand preference, age of appearance of hand preference, or early appearance is bad, not appearing in time is also bad. So this early hand preference, that means the child should hold something earlier in both hands. You will see in that case child is holding something with single hand. That means child has got difficulty with the other hand or other side of the body. So that is why it is told that hemiplegia, early hand preference, that means one-sided is used by the child frequently. Abnormal persisting, persisting frothing, abnormal posture, persistent fisting. This is the fisting, abnormal persistent fisting. That means you see the child has got one hand also always clenched. Thumb is across the palm, that is called a cortical thumb. Across the thumb, and this clenched hand is very important in case of clinical diagnosis or spastic type of upper motor neuron lesion. Persistent cortical thumb or persistent fisting, abnormal posture like that, you're one-sided, non-moving lateral well. Gait disturbance, so I will show you what is the gait disturbance later on. You see vascular insults, porencephaly, all these things are complete, or cerebral anomalies, all these things are found. Diplegia, preterm babies, that I told you already. Associated with periventral leukemia, white matter injury, much more. Four-limb involvement with upper limbs only minimally involved, although there is significant lower extremity impairment. The lower limbs are more severely affected with extension and adduction posturing, brisk tendon jerks and contractures. So these are about the diplegia. Spastic hemiplegic CP, you see the spastic hemiplegic CP, what is the picture? There is a hemiplegic CP. So this is child is in that way, there is one side is moving less. Actually this is like this, child is keeping the hand actually up in the pocket because is trying to hide the side of the movement. This is one topographic class of quadriplegia, quadriplegia term babies. So here you see the term babies. Forelimb involvement with the upper limbs may be less impaired than lower, but substantial functional limitations exist. Upper may be affected less, but actually all limbs are affected equally almost, but a little bit distribution may be a little bit less impaired, maybe, or not always, no maybe. But substantial functional limitations exist, both upper lower limb affected. Some researchers consider quadriplegia a furtherance of diplegia. Actually, or sometimes it is in research work is thought that is extension of diplegia or like that. Opistotonic posture, this is very important. Opistotonic posture, you know what is opistotonus, like that opistotonic posture. Classically, you can see from distance on the bed, child is in opistotonic posture. See, there is cerebral palsy. Feeding difficulty, extreme feeding difficulties are there in this child. Feeding difficult, very difficult. Even advice on this regard is important. Restricted voluntary movements and motor deficits. This you see the picture of spastic quadriplegia. Spastic quadriplegic child, you see that already neck is extended backwards and all these four limbs, these are all contractual changes are there. Spastic cerebral palsy. Now, this is the commonest form of cerebral palsy. Of all cerebral palsy categories, this is the commonest form, 80%. Early diagnostic features of neural damage include persistent. What are the changes? One, you remember in cerebral palsy, two things are very important. One is there is persistence of premature reflex. Premature, that is neonatal reflex, or I like the early life reflex, which are called developmentally is associated with the birth. The child has got some reflexes, morose and all those things. But later on, what the postural reflexes, which appear also with the maturity. So what happens? This premature with the congenital reflex, that is neonatal reflexes, they do not disappear completely or partially, they remain in different ways. Along with the newer reflexes, postural reflexes do not take place properly because of the persistent lesion. So this combination of these two leads to a very bizarre and awkward and peculiar situation in cerebral palsy. We will try to understand these two things are always there. In order that insult is one way, both things are there. Premature reflexes are there and also postural reflexes are there in some way or other. Partly in different areas, part of this and part of that. That makes the whole picture is complex about the posture, movement and this and also the stability of the child. So, early diagnostic features of neural damage, what are those early features? Persistent neural reflexes, very extremely important. Feeding difficulties I have told, persistent cortical thumb, that I have told you, after 3 months of age. Cortical thumb before, so normally the cortical thumb is sometimes almost normally present in newborn, but it will disappear after 3 months of age. Seizuring, when you take the child, you show you the picture, the child is lifted with the axilla, there is seizuring, cross-legging, seizuring of the legs, stretch tendon reflex, always brisk, tendon reflex, DTR, always brisk, clasp knife muscle tone, that you know spasticity, what is clasp knife, and they have variable degrees of mental and visual handicaps, seizures and behavioral problems. In combinations or in very proportions. Now we see the what is the nature of work as shown here. Awkward position, the knees pulled together, bent, feet often turned in. These are feel turned in. And here the child is trying to, this picture is not very clear, still child is trying to hide this sided, this child is trying to put and putting the hand in, is a bigger child, so has some shameful about his own condition. So trying to put the hand inside and also coming with the dragging of the legs. So stiff and jerky or awkward movements, limbs are usually underdeveloped. This is very important. If you given in examination a child having cerebral palsy, a small child, try to take the limb length. There is almost limb length inequality on the both sides. If they hemiplegia, you will see the difference in the limb length. One side, normal side is a little bit larger than the other side. This happens more the child is say in a case of 2 years and in a child with 12 years, the difference is much more prominent in 12-year-old child. So affected child is less developed. The reasons will be explained later on. So that is these are usually underdeveloped. Due to movement is less, muscles are less developed, bones are not properly developing, circulation is less, all these things are there due to the neurologic damage on that side. So underdeveloped, increased deep tendon reflexes, most common form 70 to 80% affected. These are the spastic CP. Okay. Then spastic, none of these spastic, this spastic quadriplegia you have discussed already. So I will just go rapidly. More severe form of CP, marked motor impairment, all extremities with intellectual disability and seizures. This is very important. Intellectual disability and seizures, almost in every case, more or less. Swallowing difficulty is extremely difficult to swallow and take because supranuclear bulbar palsy. Supranuclear, often leading to aspiration, pneumonia and growth failure. These things are very important. Read carefully. What happens actually sequelae of this spastic quadriplegia, this on the human body, these changes go on. Common lesions seen severe PVL, mostly in case of diplegia, and multisystemic cortical encephalomalacia, mostly in case of HIE in case of term infants. This happens in multisystic cortical encephalomalacia, but this is case of premature babies. But this leads to spastic quadriplegia more in term babies than premature ones, but also happens in premature ones. Neurologic examination, spasticity in all extremities, decreased spontaneous movement, brisk reflex, plantar extensor, responses, all these things. Flexion, contracture, knees, elbow and wrist, present from childhood, present late childhood. Contracture starts on all these things. Associated development disabilities including speech and visual, particularly present in this group of children. That I have already told you. Now spastic diplegia, very frequently found in these cases because small babies, premature babies are very frequent in our country, particularly this part of India. Spastic diplegia is bilateral spasticity of the legs that is greater than in the arms. So legs are more affected than arms. Strongly associated with damage to the immature white matter. Immature white matter. The first clinical condition of spastic is also known as commando crawl. How do you diagnose the child is not crawling properly? What happens? Crawling. After creeping, the child starts crawling around 9 to 10 months. So what do you see? The child is like commando. You have seen the cinema Prahar like that. In that case, the commando is crawling under the bus to attack those criminals. So in that case, they draw the legs with them, only moving with the hands. Exactly in that way, that is called commando crawl. So the child cannot move the legs. And they progress with on the elbow and their hands. So that is commando crawl. You can diagnose the condition from a distance, not touching the baby in fact. So this is the commando crawl. Adductor spasticity, that is important, leading to difficulty in application of a diaper. Mother will come to and say, mother will say that I cannot put the diaper. What happens? They always put, as I try, the child is always giving scissoring of the legs and preventing the mother of putting a diaper. If there is paraspinal muscle involvement, the child may be unable to sit even, cannot sit. This also happens in upper damage is even a little more higher. Examination of the child reveals spasticity in the legs with brisk reflex, ankle close, bilateral Babinski. When the child is suspended by axilla, scissoring posture, just telling you, scissoring posture, lower extremity is important, tiptoe walking. Tiptoe walking, because there is contracture, Achilles tendon contracture will later on, and tiptoe walking starts. Intellectual development is often normal. This is the condition IQ almost normal, and seizures are minimal. This is the plus point is in diplegia, and there are many diplegic persons. In fact, scientists are there in different areas of India even. They are diplegia, moving with wheelchair and other with assisted devices. They are very intelligent and doing very high grade works and everywhere. So don't disregard these diplegic patients. They are sometimes extremely intelligent as well. So intelligence is often normal and seizures are minimal. Learning disabilities and deficiencies in other abilities such as vision because of disruption of augmented pathways. Sometimes this vision is also important. In your case, sometimes I have seen many cases, the mother does not know the child cannot see her. Only when asked, the one thing, the child is having no reflex, no menace. And ultimately you see the child do not have cortical smile, social smile. There is cortical blindness. The child actually cannot see the face of mother. So at the age of 1 year, I found a baby just few months ago. The baby is looking at the mother, but actually not seeing the face of the mother. There is no social smile. He cannot have any human face recognition. The baby is not smiling. Mother says, my child is okay, but not smiling at me. First complaint was there. No other complaint. Baby is not smiling, or other baby smile. And I diagnosed simply there is cortical blindness. So that is the thing. So it is disruption of white matter. It is very important. Like this vision, loss of vision is like cortical blindness. Most important is periventral leukomalacia, which is visualized on MRI brain. Anyway, spastic hemiplegia. These also found sometimes. The decreased, you see spontaneous movements, hand preference at a very early age. Other side not working, so one side is child is using one side. Hand preference is very early. Normal hand preference is not established before 24 months fully. So it is very early hand preference. From early, very early, you are giving toys, even the child is always approached with one hand, one side of the body, one hand. That is very easily seen. Hand preference, the arm is often more involved than the leg, and difficulty in hand manipulation obviously by 1 year of age. One thing is, remember, in corticospinal tract lesion, affection is always in the distal parts. A finger movement, hand movement is very important rather than proximal movements. Proximal affection less than the distal movement. So initially there is splaying of hand, all these things, how catching a toy. Difficulties will be seen early by the mother or other caregivers. And once this is more affection on the upper limbs than lower limbs in cortical affection. Is only one side. If it is one-sided story, say hemiplegia, even in developing brain particularly, I am asking you about developing brain, not in adult CVA. So in that case, you will see that affection is much more in the upper limb than lower limb. You can hand manipulation, obvious difficulty in hand manipulation is obvious. Within 1 year, you can understand much earlier than that. Walking is usually delayed until 18 to 24 months. Circumductive gait, you know, extremities may show growth arrest. That is very important. In your case, if you get one case like in your examination of hemiplegic gait, you have to give the limb measurement. Remember this thing, everything, girth, length. You can particularly the thumb and the growth of the thumb of the hand, upper limb, the thumb is very important, and lower limb toe is, great toe is important. That will be the smaller than the comparative side, other side, compare with the other side, they will be smaller. So limb length inequality that we call, that is very important is a hemiplegia. In growing, always think in not in adult perspective. In case of a small child who is growing, so there will be limb length inequality, not in 80-year-old man. So extreme growth arrest. Spasticity is greatest in anti-gravity muscles. And we know these things in clinics in ward you can see, if you see the case of CP, anti-gravity muscle you have to show in examination as well. Equinus deformity of the foot. That is the contracture of the heel cord contracture, equinus deformity, tip to walking, all these things you have seen earlier perhaps. Ankle clunus, you have to show these things clinically. Babinski sign, there is no, sometimes they wrongly say positive Babinski, there is nothing called positive Babinski. Babinski sign is itself the extensor plantar. So, the deep tendon reflexes increased, weakness of hand and foot dorsiflexors. You can show this thing. I told you earlier the detail, more peripheral the muscles, more greatly affected in case of corticospinal tract lesion. So more affection in fingers, wrist rather than your shoulder muscles. So you can keep the distribution of weakness in case of corticospinal lesion in your mind. Always in examination you have to show these things is also pertinent in case of adults as well. So distal movements much more affected than proximal ones. Unlike in myopathies and your dystrophinopathies, all these things are proximal affection much more. That is not a matter of discussion here. But in corticospinal tract lesion, distal movements much more affected than proximal ones. So this thing, about 1/3 of patients with seizure disorder, 20% cognitive abnormalities, and all this including mental retardation. This term is old one. I have taken the slide as much earlier. So this term is not there. Next class I will take about intellectual disability later on. So that is replaced by term intellectual disability. MRI is far more sensitive than cranial CT. The same how you always do it MRI. This you can see the coloring has been done. I jolly well we have discussed this much. You can see the one-sided story. This is hemiplegia. This is affected part and this affected leg portion, and also in case of you see both legs paraplegic with slight involvement elsewhere, diplegic. And this is you can see the both arms and legs quadriplegic. All these things are just pictures. Extrapyramidal CP. This is also very important. Sometimes found. So these accounts for 10 to 20% of cases. Clinical manifestations include athetosis, coriform movements. These things are just you read it. Later on you will be detailing, there is no time for detailing here. Later on you will see everything you must ask in examination also. You will be asked to show these things, how this means. Dystonia, ataxia, ataxic, atonic due to status marmoratus, it is a Latin term, is lesions of basal ganglia thalamus. This is mostly due to your neonatal hyperbilirubinemia that happens there mostly. Status marmoratus is very important, is from ischemia as well. Cerebral damage following encephalopathy are one of these causes. Athetoid CP, choreoathetoid discarding CP, less common than spastic, much less common, mostly spastic are found, sometimes found. Spastic CP, 50 to 20% passenger CP. Hypotonic with poor head control and marked head lag and develop variably increased tone with rigidity and dystonia over years. These develop rigidity and dystonia over years. So upper extremities are more affected than lower extremities. Feeding may be difficult. Tongue thrust, drooling may be present. It's very difficult in taking food. There's also difficulty in taking food because tongue thrust is always there and drooling always. Giving the food and coming out. Speech is affected in case of spastic one. You cannot put food inside the mouth. Very difficult to put food. Here what happens? Putting the food inside, but that is coming out. There's two different stories. Say problem is same. There is very feeding difficulty is there, but in two ways, in different ways. Speech is affected because the oropharyngeal muscles are involved. Seizures are uncommon and intellect is preserved in many patients. And these are also another thing because this damage is mostly in the basal ganglia and lower part, subcortical. I mean subcortical. So cortical damage is not much. That is why intellect is preserved. Intellect is preserved. So more cortical function is there among you whose function is more in the cortex, is more intelligent than others. Naturally, intact cortex is very important for preservation of intellect. Anyway, the next one, athetoid CP and choreographer disconnect CP. What are the causes? So more or less birth asphyxia in our country certainly, mostly basal ganglia and thalamus, cardiac trust. I told you earlier, globus pallidus bilaterally, affecting globus pallidus bilaterally. Very important. Well, actually, if a case was there a few months ago during that visit, beautiful case of cardiac trust. Anyway, so metabolic genetic disorders, mitochondrial disorders, glutamic acidosis not need to keep in all mind, and these things are all the metabolic genetic disorders. And dopa responsive dystonia, Segawa's disease, have diurnal variation of the signs and worsening dystonia in the legs during the day. This sometimes like the myopathy, you can say myasthenia gravis, as there is a diurnal variation. It's very interesting. The neurological condition also has diurnal variation. Worsening dystonia in the legs during the day. Respond to small dose of L-dopa and other cerebral fluid can be sent for neurotransmitter. Anyway, this is not very important, just keep in mind the term if anybody asks you anyway. Now, associated with comorbidities are common and include athetoid CP, this is the pain, cognitive disability, hip displacement, because the muscle tone is different. Hip displacement, muscle tone is different. This hip displacement is not due to spasticity. In spastic children, hip displacement is there due to contracture muscles and muscle pull is increased. Here, this is due to less tonia, less tone of the muscles, muscle tone is reduced. At the same time, there is ataxia and stability is less in the joint. So hip displacement is very common in this. I have seen many cases, hip displacement. Seizures, behavioral disorders, less, not that great. Less sleep disturbance, visual impairment, hearing impairment. So this is about this athetoid CP and choreographer dyskinetic CP. Ataxic CP caused by cerebellar malformation associated with other cerebellar signs, mixed CP, all these things combined. Next, athetoid dyskinetic CP. How the child sits, that is the appearance is there, like this, with the giving some support with the hand because child otherwise toppled. And fluctuating tone, this is very important. Abnormal involuntary movements disappear during sleep. These disappear like your chorea, all these things, they disappear during sleep. Many abnormal movements disappear during sleep like this also. And interferes with speaking, feeding, reaching, gabbling and others. You can kind of grab something, it falls from hand. Not like spastic one. Spastic child cannot take anything by hand. But here you can put anything in the hand. It falls from the hand. He cannot grab it properly. 20% of CP cases worm-like movements. There are irregular movements always in the muscles. Slow, uncontrolled motion, writhing or twisting in character in the face, extremities and torso. And dystonia is when held as prolonged posture, grimacing, drooling, dysarthria. You know these things, and sometimes adductor spasm found. So these are the manifestations, clinical. Movements are not very important. Ataxic CP, you see here, this movement is footsteps are drawn actually. The child is moving like this. They not pretty proper straight line or like that. So starting from here, one leg, the 1 foot is 1 foot here, 1 foot here, 1 foot here, like this. But in coordinated manner, coordination is not there. Ataxia walks bent forward with feet apart. Ataxia child walks bent forward with feet wide apart. She takes irregular steps, like a sailor on a rough sea or somebody who is drunk. Actually, child is always staggering, something like that. So, poor balance and lack of coordination, ataxic CP. Wide-based gait, depth perception usually affected, tendency to fall and stumble, inability to walk straight line, least common, 5 to 80% cases. Now, classification of cerebral palsy and major causes. This is important. Once again, come back to the same thing. Spastic diplegia, neuropathology. What is the neuropathology and major causes? Neuropathology, in MRI, you can find these things. Periventricular leukomalacia, periventricular cyst or scars in white matter, enlarged ventricles. squared of posterior ventricles. Just read theoretically, there is not much to know from your end. These headlines are given. These are the changes found. Sometimes you can give in a short note to write, like these changes you can put, and the major causes prematurity, ischemia, infection, endocrine, metabolic, like thyroid, hypothyroid, congenital hypothyroidism sometimes, and spastic quadriplegia, periventricular leukomalacia, neuropathology, multicystic encephalomalacia, cortical malformations. These can happen sometimes, like the spastic quadriplegia, these things happen very frequently in the MRI, and ischemia, infection, and endocrine, metabolic, genetic, developmental. Cause are multiple. Here also, one thing remember, this hemiplegia, you can see stroke, in utero neonatal stroke is there, focal infarct or cortical, subcortical damage and cortical malformations. Thrombophilic disorders, nowadays we know that when the patient with spastic hemiplegia comes, your coagulation profile to be done first. That is come out of your investigation. First is coagulation profile, because it's intrauterine thrombosis or what is the infarct even, either in the form of infarction or cortical damage or whatever it is. There is some, nowadays it is found that there are thrombophilic disorders actually. So infection, genetic, developmental, periventricular, hemorrhagic infection, all these things. So hematological study is important here. Extrapyramidal, athetoid discard 15%, asphyxia, symmetric scars in putamen thalamus, carnivorous scars of global blindness we have discussed, hippocampus, mitochondrial scarring of globus pallidus, caudate, putamen, brainstem, all these things they are theoretical mostly. And asphyxia, carnivorous, mitochondrial, genetic, these are the neuropathology findings. Cause of the asphyxia and carnivorous is very important, particularly mitochondrial genetic disorders are much less frequent. Now, functional classification, just this very current classification, 5 levels. These are often discussed in many places. You see, GMFCS. These are the permission taken, but showing because this copyright is there. So, this level 1 is very minor damage. Can go up. This slide is cut somewhat. Level 2 like this. Level 3 you can read, describe these things. What description is given? Just see the pictures. This child can move with the holding the handbar. The swelling handbar, and this normal child. So thereafter, this child is ultimately, this also support this needed with the either with the shoulder based crutch like this or in the wheelchair. These are level 3. Level 4, this is much more difficult. This given a support device is increased, and this is motorized. This was manual. This is motorized. It cannot move in the lower limbs as well, and ultimately this child cannot move anything from your own self-propelled. Nothing is possible. Assisted device, somebody needed to move the child is level 5. Level 4, level 5 very bad, and later on this you will see many assisted device. All these things are extremely important for the livelihood this child. Associated disorders are many things are there. Mental retardation is total averaging is done because it varies with the pattern. 60%, psychiatric disorders, OCD, obsessive compulsive disorder, emotional ability, poor attention and vigilance, seizure disorder 30 to 50%. Seizures are more common. Visual disorders, speech impairment, growth failure, orthopedic disorders. These things are associated disorders always there. Isolated CP is not there. Urinary disorders, neurologic deterioration, these are associated disorders. Miscellaneous, thermoregulation and problems of social and emotional adjustment, all these things we know. And dental problems, don't neglect these things. Dental defects need to be addressed. There are many things about the dental problems, malocclusion, because cleaning is not there, so dental, so lot of problems, caries and all these things are always there. Orthopedic disorders like muscle contracture, hip dysplasia, I told you, disc dysplasia, foot, clubfoot, scoliosis and lower limb shortening torsion. Diagnosis made clinically. Evaluation includes investigation. Made clinically. Evaluation, perinatal history, detailed neurological and developmental examination, assessment of language and learning disabilities. I tell you one thing, even in case of MBBS, your final examination, if you try to always follow at least any opportunity of neurologic examination of such a patient, don't miss that, because few cases even found in your in and around this institute regarding the examination, you will find CP more or less. A neurology case, CP, there is no dearth of these cases in our country, and try to grab every opportunity of seeing clinically in case of cerebral palsy. I tell you, that is why also I took this topic to tell you the examination you will get CP. in the anywhere. And neurologic, and if CP is there, you will give in the case. Even for undergraduate, you can show the at your level, that is also important, not always for postgraduate ones, but CP will be there always in neurology as neurology case. So, cerebral palsy should be suspect child with a low birth weight, perinatal insult, all these things, you know these things. Next. Early detection, you see, see this side clearly written. Clinical signs vary by age group. 3 to 6 months, poor head control, stiffness or hypotonia. Both, many things can happen depending on the type of condition. Scissoring of legs when picked up. 6 to 10 months, what do you mean? Does not roll over. মা বলছে বাচ্চা এটা এই পাশ থেকে ওপাশ গড়িয়ে পড়ে না, আমার বাচ্চা খুব ভালো, বিছানা থেকে পড়ে না স্যার, একদম শুয়ে থাকে। যে কনসার্ন ক্লিনিশিয়ান হয়, মাথায় টং টং করে বেল বেজে উঠলো, দ্য রিংিং ইনসাইড দ্য ব্রেন, whether it's a good thing or bad. Mother saying the 7 months old child do not roll over, যেমন শুয়ে দিই চুপচাপ শুয়ে থাকে, ও স্যার কিছু করতে না, আমার বাচ্চার মতো ভালো বাচ্চা হয় না, ডাক্তার তাকে দেখে বললো তোমার বাচ্চার মতো খারাপ বাচ্চা কম দেখা যায়। কথাটা বুঝতে পেরে কি বলছি, বুঝতে পেরেছেন? যে এইসব মাদার যেটা ভালো বলছে নাও ভালো হতে পারে। ওই যে একটা সামান্য কমপ্লেন নিয়ে এলো, বাচ্চা আমার দিকে চেয়ে হাসে না, ক্লিনিশিয়ান হলো, তার মাথা বেল বেজে উঠবে টং টং করে, কি হলো, 1 বছরের বাচ্চা হাসে না তখন অবধি। কাজেই মা যেটা ভালো বলছে সেটা ভালো নাও হতে পারে, এটা ইম্পর্টেন্ট। সে তো আর ক্লিনিশিয়ান নয় তোমাদের মতো। সো ডাজ নট রোল ওভার, asymmetric reaching or persistent fisting, difficulty bringing hands to midline. Neurology diagnosis করতে গেলে, if you want to diagnose neurological cases, you must be very concerned. Every word of the mother is important or caregiver is important. Some small clues are very important. Difficulty bringing hands to midline. বাচ্চা দুটো হাত দিয়ে জিনিস ধরে না, সামনে যখন আমি ঝুলিয়ে দিই সেই ডান হাতটা দিয়ে স্যার খালি ধরে, জানেন তো, দুটো হাতও দেয় না। ঠিক আছে, তো এই হচ্ছে ঘটনা। Difficulty bringing hands to midline. 10 months, 10 মাস, 10 months crawling asymmetrically or drags limbs, scoots or bunny hops. This is the English term. Bunny hop instead of bunny is only the moving with the bottom. Is taking the bottom and moving, just like scooter. Scoot means small wheeled vehicle, just almost touching the ground like that. It's only crawls asymmetric, triangle the limbs, or scoots or bunny hops instead of crawling. Persistent primitive, sometimes crawling is also commando call in some cases. Persistent primitive reflexes beyond expected age is highly suggested. This is very important. Early identification, enables timely intervention. All these things. These are A, B, C, D, E, F, G, H. These are the what are the findings. You know everything just in picturesque manner. Problem, best problem, loss of control, coordination, abnormal tone, abnormal strength, abnormal reflex, persistent motor delay, cognitive deficit, associated handicaps. At least the A, B, C, D, F, G, H. So the symptoms of CP in one picture. Early signs, once again the same things are 0 to 3 months. 0 to 3 months. T for floppy. This to see the floppy baby, and again this is the normal. But another thing is that I am not showing here in clinics. It will be shown anytime by anybody of us. That another thing is there. This is the total floppy. Another thing, maybe the child is floppy, but head is level at the level of the body. That is called, we'll get weak floppy or strong floppy. If you are interested later on in clinical side, we will say, discuss that. Sometimes if weak floppy is there, strong floppy is also there, having some central damage, all these things like CP. A spastic child, but otherwise floppy. Muscles are weak. Child may be spastic, but muscles are weak. And when this is in ventral suspension, body is lagging always, but head is maintained at the level sometimes, and that is stiff somewhat. So that is called strong floppy. Two things are floppy. There's weak floppy is shown here. That is the is like rag doll. What is like rag doll like, and many things are there. The clinics are very important anyway. Excessive lethargy or irritability, high pitched cry, cerebral irritability. High pitched cry, not crying at his own, is not a merrymaking thing, but is a cerebral irritation. Poor head control. There's due to everything. Or weak shark, tongue thrust, tonic bite, and feeding difficult. Tonic bite is, what is tonic bite? That is one biting the mother's nipple or the part of the breast. The mother cannot remove the child from that. Sometimes so spasm comes. It's very dangerous as well. So in that children, direct breast feeding is very difficult with the EBM. We feed with EBM anyway. Inability to perform motor skills as indicated, control hand grasp, that you have discussed already. Late infancy, while you will find the control hand grasp by 3 months. Rolling over by 5 months, independent sitting by 7 months. So this inability motor skills, these are the normal motor skills. These are the normal motor skills development, but these are not inability to perform motor skills as indicated. They cannot do these things. Early diagnosis like late infancy. Abnormal development patterns, hand preference by 12 months. I told you by 24 months. Actually, hand preference is established finally by 24 months. By 2 years of age, child has got fixed hand preference, normal child. This is already preferred by 12 months. Excessive arching of back, leg rolling, and abnormal and prolonged parachute response. I won't discuss here everything because these are all clinics. Later on, if anybody in any clinics, I will show you these things. Now, W sitting, the somewhat this bottom scooting, all these things, terms are bottom shuffling, all these things, scoots along the floor like this, sitting like this, Y, W sitting, all these things. Black not sitting in black means giving a name of the child. Black not sitting independently at the age of 4 years, not walking at 8 years bad. That is just description. Associated conditions, hearing visual discussion is given. I will not elaborate these things. What are the associated gastrointestinal, gastroesophageal reflux? So whatever taking the child in the mouth is coming out after sometimes later. So gastroesophageal reflux is very important because these are the muscle incoordination and there is no ability to take it properly. Skeletal defects, dental problems, all these things, mental problems were discussed. Physical examination, muscle tone, spasticity feels like tightness in the muscles. We know these things and you have to show it clinically also, learn it clinically, show it clinically. Get a range of motion, slowly generate these questions and action. Next. Deep tendon reflex, discuss these things. I have just enumerated balance, sitting and gait analysis, observational, computerized, instrumental. One thing is that these are not very tough things. Gait analysis is important. Last time only two students I got who came and our HOD told you tell them about gait and reflex. What they understood, something I don't know. So this gait and what is gait? Anybody? I told someone, two of you perhaps, I don't know. Can you anybody tell about what is gait? Gait, G-I-T gait, not G-A-T, G-I-T gait. Gait is the composite movement of pelvis or lower limbs when a person tries to move smoothly on a horizontal ground. So that is the definition of gait. It is not hand, it is not leg isolated. It is a composite movement of pelvis and lower limbs. When a person tries to move smoothly on a horizontal ground, not by hip hop, not in a slantwise, not in a slant area like that. So that is gait is very important here. Crouch gait, jumping gait, high stepping gait, scissoring gait, to and apron, all these things. Now, this is one thing I show you, just what is meant by these things. Primary impairment, muscle tone, balance, strength and selectivity directly related to damage in the CNS. This is primary impairment. Leading to secondary impairment. This is an example, I am showing the example. Secondary impairment, muscle contracture, deformities develop in response to the primary problems and musculoskeletal growth. So these are the actual primary problems here. Secondary things happening here. Tertiary impairment, adaptive mechanisms and coping responses that the child develops to adapt the primary and secondary problems. Udaharan ki, an example there, gastrocnemius spasticity as a primary impairment, leading to secondary ankle plantar flexion contracture and knee hyperextension in stance as adaptive mechanism. As an adaptive mechanism, the child is trying to cope with the situation, cope with the life. So that is, there are some changes in the movement, posture, gait, everything. Investigations, the neurologic, I should be rapid much more. Clinical history, So this is the investigation laboratory studies, clinical history not usually not done unless indicated. Additional type features and all these things, pyruvate. I mean if there are inborn errors of metabolism, all these things not done always. Any suspicion, then only do these things. Imaging, early neonatal period, cranial ultrasonography, as long as anterior fontanelle is open, may show evidence of hemorrhage, hypoxia, HIE, PVL. A CT scan is much less done. MRI is done actually. 2, 3. Only CT scan is superior to MRI in case of showing hemorrhage and any bone or this fracture or all these things. Otherwise, we do always MRI. 2 to 3 weeks of life, older children is done in older children. And CT is only superior in case of showing there is structure damage to the skeleton and also one for hemorrhage only. Okay. Next, electroencephalography, electromyography, all these things, nerve conduction studies, muscular nerve disorder suspected. Neurodegenerative, failure to thrive, vomiting, and loss of acquired skills, neurodegeneration, there is regression of milestones and others are found. Only that case you find, we'll think about the neurodegenerative. Hydrocephalus, subdural effusion, class taken last time, you know these things, now will not discuss. Brain tumors as well. Muscle disorders, congenital myopathies and muscular dystrophies, you know these things. These are all, distribution is different. Distribution is different. Muscle weakness, hypotonia, creatine phosphokinase PK, EMG, muscle biopsy, adductional injector. These are for theoretical interest in class, but these are not found always. Management approach, individualized, holistic and multidisciplinary. No single person, no single doctor. One thing is the law of the land is no single doctor should try to manage cerebral palsy. If you ever get a cerebral palsy, you send in proper center or tertiary center where a combined holistic treatment can be given. No single doctor should treat a case of cerebral palsy. It is the law of the land. Now, the management plan, So management plan directed severity, type of neurologic deficit, associated problems. Because there are so many associated problems. Goals of management, psychological development, communication, education. Maximizing quality of life. So what our aim, we cannot, we cannot go back in time. Time machine, there is no time machine. What we can do maximum, that is maximizing, we can offer as far as possible a meaningful life to the child. That is a very important term. So what is the goal of treatment of cerebral palsy? Or answer in the examination, sir, we try to give a meaningful life to the child. Only in one sentence, and gold medal answer. Trying to give a meaningful life to the child. That is important. Pharmacotherapy, botulinum toxin, all these things, these are all not for you always, just keep the names in mind. Muscle tone interferes with function and lead to contracture, older children more than 18 months. Oral antispasmodic drug, baclofen, this baclofen, pump, all these things are come. Dantrolene helps relax and skeletal muscles. These will not be asked many things. If in a theory examination, all these things, yeah, sometimes you may be asked. So, occupational therapy, educational, orthopedic support, tendon, muscle, bone surgery, all this neurosurgery, selective dorsal isotomy. This is important. This has come up recently, stereotactic thalamotomy, encephalotomy, thalamotomy, and this selective dorsal isotomy. These are so many things, not for you. Just keep the thing in mind. These are all postgraduate things. Endocles and cortical thumb. Achha. These lightweight splints may be required. The cortical thumb is important. If you don't improve somewhat in this child, hands will be useless. You know the most important part of the hand. What is the most important part of the hand? Which function of hand? Function of the thumb. If you don't have function in your hand or thumb function, your 90% use of the hand is useless actually. So this cortical thumb is very important, small thing, but if you can improve this condition, you will have the hand function somewhat. It is important. Occupational therapy, focus on development of fine motor skills and self-care skills. এগুলোর জন্য কিন্তু hand movement লাগবে. Fine motor skills and self-care, using exercise, facilitate practice, all these things. To promote child's independent participation, daily activities. This is very important. Independent participation in daily activities and routines in the home, school and community as far as possible. And difficulties in feeding and swallowing. This is for mother, this is very important. Mother will come to you frequently and will complain, I cannot make the child feed, is problem with this, cannot swallow, all these things. Remember, these things must be addressed properly. Selective dorsal isotomy, I will not discuss anything about you. This is not for you, just for the headings. You read it later on. Assistive device, there are so many devices. Assistive device, just giving the picture, these things, assistive device. These things are, they are sitting, these things, you know, is not much to read. Just these things are epilepsy. This is very important. Epilepsy is spastic hemiplegia. Most often, there's 35%, most of it is spastic hemiplegia. Remember this thing, spastic hemiplegia has got highest epilepsy conditions, followed by quadriplegia and diplegia. Many persons give the wrong answer of quadriplegia, but highest is hemiplegia, spastic hemiplegia. And seizures difficult to control. Polytherapy is a different, many drugs may be needed, and most children will onset seizures first and second year of life. A significant correlation found between mental retardation, intellectual disability, microcephaly, and all these things. Visual problems, I have told you earlier, so that is also important to be addressed. Then behavior problems, sleep problems, all this to be addressed. Aggression and sometimes behavioral problems are there. Hyperactivity, destructive behavior, drugs needed, all these things. Methylphenidate, haloperidol, and later on night sedatives. These are very important at home. If you have for frequenter in your chamber with a patient of CP. So this they will ask, child is not sleeping at night and causing a lot many problem at home. So night still like chloride, non-barbiturate hypnotic. Don't try to give any child a barbiturate hypnotics. Non-barbiturate hypnotics like chlorhydrate and sometimes melatonin. Also, it has come up of late, is very good. Very good substance for sleeping at night, for sleep at night. So melatonin to be given, all these things. Parent counseling extremely important. What is the situation, how to handle, and all these things we discuss. Management, social, I have discussed. So social is family and all this discussion. Rehabilitation, vocational guidance. This is also important. You have to discuss with the psychologist or psychiatrist as well. They is also part of the team. Play therapy is natural activity with the young child. This is important to give a meaningful life. Natural play is not less than the other treatments. So try to cope with the child, try to activity as far as possible. The child must cope with the situation. Natural activity of the young child to help him consider the levels of development, all this. Parents are also taught in the Parents are also taught to progress like this. Then prognosis of independent walking. Important, this slide is important for you. This is very important slide. Oh, 11. Very important. Just see this thing carefully. Primitive reflex disappear in less than 6 months. Poor prognosis persists more than 2 years. Primitive reflex persisting for more than 2 years, very problematic. Head control attained by 9 months, not attained by 20. Poor prognosis. What are the indicators of poor prognosis? If attained by 9 months, it is good prognosis. Not attained by 20 months. Sitting there is important. No, attained by 24 months is very good. Not attained by 36 months. Thing is that it's not attained by 48 months, very bad. And floor mobility attained by 30 months, not attained by 48 months. Independent crawling, symmetrical reciprocally. But not attained by 48 months, independent crawling, but symmetrical reciprocally is very bad. And approximately 80% of hemiplegics walk by the age of 2 years and 5 years. At 5 years, 60% of tetraplegics and 65% of dyskinetic children walk. But 80% of hemiplegics walk by age of 2 years. It is important. One thing is that if the child cannot sit by 3 years of age, remember, by 3 years of age, you have tell the parents there's very little chance of walking. And if by 4 years the child cannot sit independently, there is no chance of walking. So by 2 years, if cannot sit by 2 years, there is a chance of 40% chance of walking. I tell you not to put here. If the by 3 years cannot sit independently, 20% chance of walking, future walking, and cannot sit by 4 years, nil, 0% chance of walking. So we can tell this prognosis is very important. So prevention of CP, I have added this slide recently. This is important because decreased risk of CP, if magnesium sulfate, you do in gynecology in your obstetrics, the magnesium sulfate is given in preterm labor. This has come up, not due to this convulsion, all these things. In mother, magnesium sulfate is given in preterm labor. You know the corticosteroid, antenatal corticosteroid national program, in case of impending preterm labor, you must give it, otherwise you will face medical legal consequence even. So antenatal corticosteroid is also there for lung maturity, interventricular hemorrhage, all these things. I have not discussed here in detail, but that is your national program. Here also, mother should give magnesium sulfate is given in preterm labor. Decreased risk of CP by optimizing term of preterm delivery, therapeutic hypothermia. In after birth, there are many centers nowadays also Kolkata, therapeutic hypothermia, they are doing therapeutic hypothermia very successfully, and in prenatal asphyxia they are giving good results in case of Bhagirathi Neuti and others. So they are doing therapeutic hypothermia, and treatment of twin-twin transfusion by radiofrequency ablation. This is very important. In twin-twin transfusion, one twin emaciated, dead or otherwise, the other twin is also affected by CP. So what they do after diagnosis is the radiofrequency ablation or abnormal circulation. They are blocking this radiofrequency ablation, and at term they are taking out the baby, living baby in very good form. So that is in a nutshell this very big topic. I have completed this today, and next we'll see you again next class.